Eosinophilic esophagitis is a chronic inflammatory condition of the esophagus. It is characterized by an infiltration of eosinophils and fibrosis. This condition is the leading cause of difficulty swallowing in young individuals. It is becoming increasingly recognized, with approximately 50 cases per 100,000 people. It is more common in males and typically presents in the third or fourth decade of life. Diagnosing eosinophilic esophagitis requires clinical symptoms, primarily difficulty swallowing, and histological evidence of eosinophilic infiltration in esophageal biopsies. Treatment options include proton pump inhibitors, topical corticosteroids, and dietary modifications. The prevalence of eosinophilic esophagitis is about 50 cases per 100,000 individuals, with a higher incidence in males. It is often associated with a history of asthma, allergic rhinitis, or other allergic conditions. The median age at diagnosis is between 30 and 40 years. The delay between the onset of symptoms and diagnosis can range from 4 to 6 years, with some patients being diagnosed more than a decade after their first symptoms. The primary symptom of eosinophilic esophagitis is difficulty swallowing, especially with solid foods. Patients may also experience food impaction, which can lead to emergency room visits. Other symptoms include chest pain, particularly after consuming acidic foods or wine, and symptoms similar to gastroesophageal reflux disease. In children, symptoms may include vomiting, abdominal pain, and poor growth. Patients often adapt by chewing food extensively, drinking liquids during meals, and avoiding certain foods, impacting their quality of life. Endoscopy is essential for diagnosing eosinophilic esophagitis. Common findings include concentric rings, longitudinal furrows, white exudates, and edema. The EREF scoring system is used to assess the severity of endoscopic lesions. However, up to 30% of patients may have a normal-appearing esophagus on endoscopy, making biopsies necessary for diagnosis. During endoscopy, at least 6 biopsies from different esophageal sites are recommended, even if the esophagus appears normal. Histopathology confirms the diagnosis when more than 15 eosinophils per high-power field are present in the biopsies. Allergy testing is not routinely recommended, but may be considered if immediate hypersensitivity reactions are suspected. Barium swallow can help assess esophageal strictures or narrowing. Manometry is not routinely used, but may be considered if motility disorders are suspected. Proton pump inhibitors are the first-line treatment, with about 50% achieving histological remission and 60% achieving clinical remission. Treatment usually lasts 8 to 12 weeks, with maintenance therapy as needed. Topical corticosteroids are effective for inducing clinical and histological remission. Budesonide orodispersible tablets are commonly used, especially if proton pump inhibitors are ineffective. Dietary modifications, such as elimination diets, can be effective, with response rates of up to 80%. A step-up approach, starting with fewer food eliminations, may be used to improve patient adherence. Endoscopic dilation is recommended for esophageal strictures or narrowing. It is effective and can be safely combined with medical therapy. Eosinophilic esophagitis is a chronic condition with a high risk of symptom recurrence after stopping treatment. Long-term maintenance therapy is often needed to prevent relapse and fibrosis. Regular follow-up, including endoscopy and biopsies, is recommended to monitor treatment response and disease progression. The risk of esophageal cancer in patients with eosinophilic esophagitis is not increased. Eosinophilic esophagitis is a chronic inflammatory condition that primarily causes difficulty swallowing in young individuals. Diagnosis requires endoscopy with biopsies showing more than 15 eosinophils per high-power field. First-line treatments include proton pump inhibitors, topical corticosteroids, and dietary modifications. Endoscopic dilation effectively manages strictures. Long-term maintenance therapy is often necessary to prevent recurrence and fibrosis. Regular follow-up is essential to monitor disease progression and treatment response.